Welcome, everyone, to the next session in our series addressing pediatric feeding disorders in schools. Today's topic is training and implementation, and I will turn it over to Jennifer Eggert, our presenter.
Thank you, Dawn. Welcome back, everybody. If you're coming back for another session or if you're here for the first time, welcome for the first time. And I'm assuming a lot of you will be watching this on recording. So I'm glad you could all be with us to continue this journey as we look at this really important topic. So we're going to jump right into our second slide there. Thinking about where we've been. We just sort of reviewed in the last session that before we do training, school districts should have adopted a plan and procedures that includes identified team members. I put the good old first then boxes there because I thought it was just so perfect of a representation of this is a process. And we recognize that this is a process. And we've been trying to give you big pieces of information. We've been trying to give you very specific pieces of information. And last time we spent some time talking about what does a school and district need to have. So in looking at the flow chart on the next slide, we had talked about a pretty specific process, starting with referral, case history and obtaining medical records, going into interdisciplinary interview and assessment, followed by the IEP process, the development of safe eating plan and a health emergency plan, and then where we're going to be at today, training of personnel, and consultation and monitoring, and then as needed, revision of the IEP and safe eating plan when indicated. So if you're interested in that information, if you missed it last month, it is in the recording. The first thing that we need to do when we are looking at training and implementation is to assess the competency standards of our district staff or our school staff. So it is suggested that you survey the school or district staff to determine their training and experience levels with pediatric feeding disorders or PFD, and also with feeding and swallowing. And then you should look at designing a school or district plan for obtaining or updating skills, remembering that this will look different for each team member and discipline. So a speech therapist may have a very different plan for obtaining or updating skills than perhaps a paraprofessional or a special educator, as would an occupational therapist have a different look at their skills that they need. So again, really making sure that this is specific to the competencies and standards of each of your professions. On the next slide, we talk about some opportunities for professional development, and I want to give credit to Dawn for helping me to come up with this list. There's so many different ways that we learn nowadays, and I do think it's useful to just remind ourselves of all of the different ways that we do things. This is an example of a webinar and recorded session. Shared learning is a great opportunity. There are lots of university-sponsored sessions. If you're not familiar with the university-sponsored sessions in the state, certainly reach out to Dawn or I. We're more than happy to connect you with some of those continuing ed opportunities. Professional organization conventions, for example, the Wisconsin Speech and Hearing Association is having a convention that's starting this week. And most of the professions here have their own professional organization conventions, both in the state and in all the states in this country. Hospital-sponsored trainings are also an option for you. And that could be both a paid opportunity, or sometimes there are, again, therapists on site at hospitals that will do that shared learning with you. Opportunities for professionals to meet and discuss cases or journal groups. Mentoring of SLPs without experience by those with hospital experience. Reading current research is really, really important, especially as this is an area that is really evolving and changing and growing quite quickly. Researching and preparing a presentation. They always say, if you can teach it, you know it. And so certainly getting into it and understanding it will help you. And then observing other professionals. So looking at all of those pieces of professional development, just a reminder. So today we're going to spend some time not going through each of the different disciplines specifically and what they could do in terms of training and implementation, but looking at this from a bigger picture model. And one of the things that I thought was really important for us to talk about was the idea of coaching and training and mentoring. And what does that look like for us as professionals? You know, I think lots of times we are put in a position where we are saying, okay, well, teach this person. And we know how to teach. We are all educational professionals. But knowing how to coach somebody, knowing how to train somebody, knowing how to mentor somebody is a totally different thing. So let's just start by defining the differences between those three. Coaching is a personalized and goal-oriented approach that focuses on enhancing an individual's skills and performance. And we often think of coaching as in a sport, but coaching is a real big buzzword in the last 10 to 15 years in all areas of business and professional practice. Training is a structured process aimed at imparting specific knowledge and skills to individuals or groups. We all go through trainings. We've been through trainings, for example, on, say, some of you have been on trainings for CPR, or you've been in trainings for beginning of the year and playground rules. There's all sorts of different trainings that are out there, right? Mentoring is more of a relationship-based approach in which experienced individuals provide guidance, advice, and support to someone who's less experienced. So training is really commonly used to develop technical proficiencies and maintain compliance with industry standards. It's really a vital tool for building competence and ensuring that individuals can perform their roles effectively. And we use it quite often. I want to often also note to you here that the DPI coaching webpage is linked here. It's a great resource for specifics on how to participate in coaching, how to receive coaching, how to give coaching, and wanted to make sure that you had that there. On the next slide, let's talk a little bit about training. What are the key characteristics of training? Again, I think as adults, we forget that adults are learners too, and adult learners have specific ways that we learn. And they're not really that different from what we do with children or teenagers or young adults. So the first key characteristic of training is a structured curriculum, which you are all very familiar with. And so all training programs should have a well-defined curriculum. Instructor-led is the idea that a trainer, who's often a specialist in the subject matter, leads the training sessions. Now, in the event of not having somebody in your school or district with specialty in pediatric feeding disorder, perhaps you are as a team watching these trainings, perhaps you are bringing somebody in. There are options for that, knowing that, again, you don't have to have that instructor-led trainer be a member of your team. They could be somebody that's external. Skill acquisition is the focus is on acquiring or improving a particular skill set. And again, this is something that we do across the board with all of our students. And standardized is meaning that the training aims to ensure consistency and uniformity in skills and knowledge. So again, we're making sure that everybody is being trained to the same level, consistency, and that we are doing this with uniformity so that everybody has the same information. We don't want somebody to say, well, they told me this or they told me this. We want everyone to have that same skills and knowledge so that we are making sure we are doing this consistently. All right. So how do we get to training of caregivers and students? Well, first of all, I think we need to think about identifying pieces of this. So identifying emotions. Are people nervous? Are they excited? Thinking about putting those two together and using one of my favorite words, which is nerve-sighted. Are they nerve-sighted? So identifying the emotions of the caregivers and the students. Are they relieved? Recognize that caregivers and the students are experts. Caregivers are experts in their student, and students are experts in themselves. Family engagement is going to be vital to success. We know that. Do they want to be involved in the training process? Some caregivers may be very hands-off. They may say, you know what? I feel that you are the professionals and that you should be doing this. We'll talk about an example of that in a moment in culture. What does the training look like? Are the parents involved? Are they doing part of the training? Is the caregiver somebody who is demonstrating skills for us? Are they describing? Are they providing us with videotaped evidence of what works and what doesn't work? And are there family dynamics that need to be considered? So this could be, for example, maybe between two different caregivers who have differing of opinions on how something should be done. Or do they have a caregiver saying, this is what we've told been safe, versus a student saying, but this is how I want to do it. And that's really common. We see that across all populations in our pediatric or in our feeding population. And that sometimes somebody could be told, you know what, you will aspirate on that, and they will say, I'm okay with that. Like, this is a decision that I'm making against medical advice. This is what I want to do. And so we have to be really careful of those family dynamics, especially with us in the school districts, in any situation of looking at liability too, right? Another important dynamic that is often out there is the school bringing in a private duty nurse. And I have worked with many private duty nurses, and they are amazing individuals. But sometimes they have an opinion about how things should be done, which may be different from how the caregiver wants things done, which may be different from what the professionals in the medical team said can be done. So we have to really take into consideration all of those pieces, read what is best for that student, what is safest for that student, and then still give credit to the opinions of the other people involved in this individual's care. Culture is, of course, a huge consideration, thinking about cultural values and social norms. This includes food preferences and what individuals may or may not be exposed to, and non-allergy dietary restrictions, such as individuals who may be of certain religions who avoid pork or who are vegetarian, in addition to feeding norms. So there are some cultures where it is very typical for individuals to allow caregivers to feed children until 3, 4, 5 years of age. It's not atypical. It is not atypical for, in some cultures, for people to what we call pre-masticate, to pre-chew meat and then give it to children. That is something that is typical. Thinking about too, going back to that recognition of the caregiver being experts, and they may just say, no, you're the expert. So I think a lot about, I've worked a lot with the Latino population, and they have very often said to me, no, you are the maestra, you are the teacher, you tell us what to do. And so, I love being respectful of that and recognizing that, because that's so important to them. They see us as somebody who is very important in their lives, and that we should be the experts. Okay, let's think about training in regards to teams then. So identifying the nervousness or nerve-sided or excitedness of the team members. And again, or are they relieved? Finally, we're going to be able to understand little Ricky's feeding pieces, and we can involve him in this process. Recognizing that team members are experts, but also learners, and their engagement will also be vital to success. We all know those team members that we have that aren't maybe as engaged as we'd like them to be. And so how do we facilitate that? Because that can certainly be a very big challenge and a very big safety concern in the PFD population. And then looking at our team culture. So what is the shared values, behaviors, and working practices of a group of people working together? And this should be shaped by and looked at by the team's history, leadership, and members. And again, we know that there are some teams that have wonderful history together. And realistically, we know that there are some teams that are struggling to work together. And it's important that we recognize that when we are looking at training somebody. All right. So, in looking at some just generic training considerations, I want you to think for a moment, how does it feel to be in the role of a learner? What helps you to stay engaged, and what is your learning style? Maybe throw that in the chat. Let's just think about that for a second. How does it feel to be in the role of a learner? You're all in the role of the learner right now. What helps you to stay engaged? What is your learning style? So for me, when I'm in the role of the learner, I like to at least have some prior knowledge. It helps me to stay engaged if I can ask questions, if I can have visual resources to be supporting me. My learning style is very multimodality. I want to be looking at things. I want to be reading pieces. I want to be hearing individuals tell me. I want to be doing the hands-on piece. And so that to me is what's really important when I am being trained. Again, if you want to throw anything in the chat as far as your experiences of being the learner, or just think about that for yourself for a minute, because it is an important consideration. I think it always helps to be in the learner, in the role of a learner, if you understand the relationship and the mindset, right? So the relationship, in order to learn and grow, team members must be willing to be vulnerable, navigate setbacks, and reveal intentions. Laura said, I love to externally process information, talk to others, ask questions. I need to take notes. Yeah, that's great. Externally processing information. I would agree with that 100%. Mindset, when you are in the role of the learner, is to understand that the trainer has to be able to suspend judgments of the situation, right? We think about things not being only black and white. We have to think about maybe and. So perhaps they aren't doing as well as they could be, and perhaps they are still trying their best. Just think about that for a minute. Both are true. And so suspending that judgment, that's really important when we're training somebody. So another example of training that I like to use when I'm working with individuals here on the next slide is the idea of, again, that vulnerability and having those communications, those open conversations with people as far as stop, start, and continue. So start, offer a suggestion of something this person could start doing to better support your learning. Give an example of how it can help you to learn. Stop, offer a suggestion of something this person could stop doing as it hinders your learning. Give an example of how it may disadvantage your learning. And continue. Offer positive feedback on something this person could continue doing as it supports your learning. And again, give an example of how you've benefited from it. I use this with the students that I supervise clinically at Marquette University. As a matter of fact, today I just sent them out an email and I said, I want you to tell me your goals for yourself. And I also want you to tell me, what am I doing well? And what do you need me to continue doing? And are there things that you don't want me to do? We're a couple weeks into clinic now, and I need them to start taking some onus of giving me this feedback. And it's really difficult sometimes to give feedback when you're in that trainer-trainee relationship. And so these types of communication can really, really open up that flow and make the individual feel like, wow, I really can come to you. You do trust what I have to say, and it's important to you. Okay. The other thing is, again, moving towards a learning conversation. So learning together, having a message to deliver versus just information to share and questions to ask. Blame versus contribution. Remember that blame is about judging and looks backwards, and contribution is about understanding and looks forward. And there's that and stance. Again, everyone's feelings are acknowledged and no one is diminished or dismissed. So again, I really appreciate everybody spending some time on going through these slides. We have one more on just thinking about how we are as learners, because it is so important when we're working with children with PFD that we are safe and that we are going for that goal of inclusion. But it can be tricky. And we want to make sure that we are recognizing and acknowledging all the feelings in the room and all of the relationships in the room so that we can, again, support these children and these students as best as we can. So thinking about creating a learning conversation, I'm a speech therapist, and so I can't help but give you an example from the communication standpoint, even though we're talking about feeding and swallowing. So when we think about training and mentoring and coaching, it's really important to think about the conversation styles we're having, including learning conversations. So oftentimes we start by describing a problem from our perspective. And what happens is this communicates judgment and results in defense. And we all know that there are individuals who are and can become very, very easily defensive, right? And we know who those individuals are. And we recognize that is a piece of who they are. And that is important for them to be able to defend themselves. But instead, what if we initiated stories from the perspective of a mediator or an outside observer? So instead of saying to your colleague, you really shouldn't have put me down in front of our principal, how different would it be if you said, I wanted to talk to you about what happened in the meeting this morning. I was upset by something you said in front of our principal. I wanted to explain what was bothering me and also hear your perspective on the situation. Those are two different conversations. And the second one is certainly much more inviting and will certainly lead to less defense. So think about just for a second, if you want to pop it in the chat, think about any concerns you have about training and implementation specific to thinking about the individuals you're going to be working with and the relationships you have with them. And again, this is all confidential. I won't read any names here or anything, so keep that information confidential. But I would think that there will be people. Just raise your hand. Raise your hand in the chat if you are concerned, thinking, I might be training people who don't want to hear this information or who are going to fight against me on this information. I'm going to give it a second to see if the chat fills up here with anything, because I know we need time to type, and we've got bandwidth differences across the state, and some of you are getting snow and some of you are getting ice, and some of us, myself included, have a dog that's barking in the background that I would like to acknowledge that is making me less than open to anything my dog is going to want to do afterwards. She's not going to get to go on a very long walk. She wasn't listening well. All right. Well, it doesn't look like anybody's popping in the chat here. Oh, here we go.
Goes.
There we
Jennifer,
go.
can you give the prompt again?
Yes. Raise your hand if you are concerned about training people, if you are concerned about individuals and personalities and who you may be working with. Somebody here says, I have a parent that does not have concerns and does not want me to be worried about her child. That's a really, really great example, because you are having to look at this child from a safety standpoint and looking at one of the most important people in this relationship, which is the parent. Somebody else here is saying, I don't think resistive to the training, but more so nervous about safety and repercussions if an unsafe situation occurs. So this person's statement is less about relationship based and more about, again, the things that we've talked about in the past as far as being safe, right? This next individual here is saying, I have concerns about the cost and time involvement with training 180 plus staff members. That is a legitimate concern. Thank you for sharing that. Yes, that is a huge concern. That's why we're doing these webinars the way we're doing them. We're trying to be efficient, right? Right, we'll just see if anybody else here throws it in the chat. And perhaps some of you are driving or doing other things, and so you can't raise your hands. But I'm kind of hoping that maybe people do have really great relationships with their team members and they aren't concerned about training team members. Safety factors are more concerned when their beliefs do not align. Yes. So there are people who think like, hey, I can multitask and I can feed this person and I can be talking to somebody else at the same time, when that may not be what's the best for that student. That's another great example. Thank you for putting that in the chat to that person. Okay, we'll move on to the next slide, knowing that if anything else pops in the chat, I can certainly come back to it. So thinking about moving away from that relationship of training somebody and what team relationships can look at like, and moving into training to feed somebody specifically, I want to spend a little bit of time talking about things that will be useful. So the student with PFD may very often be completely dependent on the feeder. And so it's really important and useful to do a few things. First of all, talk to the student. Tell them you're presenting another bite. Describe or name what you are feeding them. So for example, I might say, all right, Alfonso, I'm getting ready to give you another bite. I'm giving you some more of your chicken and rice. I've made sure it's cooled off. We've blown on it a little bit. Here it comes. Or saying to them, hello, Jaquel, I'm here to feed you today. I know that you like to poke the food yourself. I'm going to put my hand on your hand and poke it with you. And there you go. You got that fork into that nice juicy orange. Let's take a bite together. Being focused on only the student, no side conversations, is really important. And then staying calm. It can be really nerve-wracking when you're learning to do this. Let's all admit that. But students can sense your nerves and they may respond to your emotions. So another emotion that sometimes we admittingly come to any situation with could be anger. You just had a situation that really, really frustrated you, and you come in and you're like, time to eat. All right, let's do it. And without even thinking about it, you're using this moment to get some of that anger out. And this poor student who's completely dependent on you is simply sort of the bag in your punching bag moment here. So we really have to take a moment, take a deep breath, focus on that task, stay calm, leave whatever other emotions we have at the door. I'm just curious if anybody has ever been fed by someone. Think about that experience. I put some pictures here. The first one is a picture from the TV show The Office, where I think it's I forget the name of the character, but it's terrifying. Melissa said it's terrifying being fed by somebody.
My goal is trying to get Kevin to eat healthy. So he's forcing broccoli on him. It's like, sorry.
Yeah, no, I appreciate that. Yes. And so he's saying, eat it, like it, eat it. And he's literally shoving it in his face. And he does not look happy, does he? Michael is trying to force feed Kevin, and Kevin does not want the broccoli. I wouldn't want the broccoli. If you look at that second picture there, I thought that picture was kind of unique. It looks like a couple that maybe isn't engaging in some loving and playful interactions with food, but look at how wide open that man's mouth is. He is ready. Like, she is not going to miss. I am wearing a nice white shirt. I don't want to get a mess all over me. And if you look at that third picture, this third picture made me think of the age-old tradition of the bride and the groom feeding each other cake. And how often you see, thinking wedding cake in the anticipation. Yes, thank you, Valerie. And how often you see that bride and groom take each other's hand while they're trying to feed each other because they're terrified that they're going to miss, that they're going to smash it in their face, that it's going to go too fast. It's your wedding day. You don't want to mess. You don't want to choke. That last picture there to me says, I'm scared. Even though I'm accepting this food, I'm a little nervous. And so think about ever being fed by somebody and thinking about that experience. It can be very terrifying. It's all about giving up control, right? So thinking about types of trainings, procedural trainings are going to be our focus today. We're going to talk about the specific steps in the safe eating plan and discipline-specific recommendations. And again, we've given you lots of examples in previous trainings about how to come up with those safe eating plans and specific recommendations. But there's also, and it sounds like some of you have this experience coming up, is knowledge and skill trainings, where you are expected to give some sort of big training to all of the staff specific to a skill set. And that is a very specific training. That's a specific skill set that you'll be teaching. And we're not going to focus on that so much today, again, because you would be doing that. Maybe you're doing a training for all of the speech therapists in your district or all of the special ed people in your district. But we're going to look at that procedural focus. So let's look at the next slide. So in terms of procedural training, let's talk about the who. In your school and district, it will be important to think about who will be leading the training. And will others also be involved in that training process? So will it be the speech therapist leading the training? Will it be the occupational therapist leading the training? Will it be a team of you leading the training? Another question related to the who of procedural trainings is, how many people will be trained to feed a student? Now, some of the individuals that Dawn and I have learned from really recommend that 3 is the minimum recommendation for the number of individuals who should be trained to feed a student. So for example, 1 or 2 paraprofessionals and maybe a special ed teacher, or maybe a paraprofessional, a special ed teacher, and a regular ed teacher. Maybe there's an administrator involved due to staffing concerns. We don't know who those people will be in your district, but the recommendation is that there's a minimum of 3 people trained. Again, given that sometimes people have days off, sometimes people are sick, sometimes people are pulled away for other responsibilities. All right, looking at the why and who. Why are we doing this? We need to give a definition of PFD and the basics of feeding and swallowing. The the signs and symptoms of pediatric feeding disorder, which we went through way in the beginning, the red flags, the coughing, the choking, the gagging. If you're talking about coughing and choking and gagging, don't forget we talked about this and we said coughing and gagging can be signs of PFD, but they are also something that are protective. So coughing means you're protecting your airway. Gagging means you are protecting your airway. Choking is pure silence. There is no air coming out. Turning red, turning white, turning blue. Because remember, caregivers will often say, oh, they choke all the time. No, individuals don't choke all the time. They shouldn't be choking all the time. Most of the time, they're coughing and gagging. Thinking about the legal and ethical implications, including an overview of school and district policy and procedures involving the referral process will be important in your training. And then thinking again about the team members and the delineation of roles and responsibilities. Who is all involved in this, not in doing the training, but who are the team members that are involved in your feeding team, in your school safe eating plan, in your school's IEP development? Who's going to be part of all of this to make sure that this student is safely eating? Thinking about the what, the where, and the how of procedural training, think about considering where this information will be housed for access. So is this something that's in a Google form, in a Google site, in a SharePoint site? Is there some sort of an record keeping site that you all use? Is there, if you use, I'm thinking about Microsoft Office, if you use SharePoint or OneDrive rather, is there a OneDrive folder that is specific for all of this information? Again, what happens a lot is people come up with ideas, people come up with forms, people come up with PowerPoints or slide decks, and they just kind of get thrown everywhere. And so can it all be housed together and made that way so that it's easily accessed? Be sure to include pictures and detailed steps and explanations. I can't stress this enough. You can tell me how to seat little Felicity, but until I see it, I may not understand it. And if I can see it in the equipment that is at the school, that is a huge piece, okay? Because the equipment that they have at school, that high chair that they use at school, that's at home may be different from the high chair that you have at school. The special Rifton chair that they have at school might be different from, say, the tomato seat that they have at home. So include pictures, and when you can, do it pictures of them in the equipment at school. And then detailed steps and explanations. Again, assume that people know nothing, right? Assume that your trainee, that your learner, that your feeder needs to know every single step so that it is all written down and that we all do have that equity of information. And then again, if we can look back at it, if we need to, make sure we aren't missing any steps. Now, we're hoping that in some cases, daily documentation may be used, and this would be beneficial for individuals who maybe were working with district nursing on documenting intake. There may be concerns for weight and growth. And so if there is daily documentation, thinking about, is there a district form or some sort of pre-made form that's being used? We gave you some examples of some forms previously. Is it possible to create a form with input from team members who will be feeding on a daily basis? I think there's nothing worse than being given something and saying, do this, versus saying, we have to do this. How can we create a space where we can document this together? And what's going to be realistic? Because my idea of what's realistic and what could be documented may be very, very different from a paraprofessional or a special ed teacher who has to do not only documentation for this student, but for 5 other students in that day. And that's not even related to their IEP goals specific to learning. That's related to their IEP goals just for safe feeding and swallowing. And so it will be really important, again, for that team to say, can we create these forms together? What's going to be realistic for us? What's going to be efficient for us? And then what information is most important and needs to be included? And this will be likely very student specific. So again, maybe brainstorming together, looking back at some of the examples we've given you of what are the pieces of information that need to be included in general, and then taking that form and maybe highlighting it specifically for each student, or maybe paring it down for each student so that there's simply less information to look at. All right, next slide.
And there was a comment earlier when you were talking about training that said, at times there are staff who have done this before with other students and don't seem open to my suggestions. And I'm thinking, this last part that you just talked about, where there may be some general information, but then there's information specific to different students. I think that might be helpful in a situation such as that.
Yeah, absolutely. I'm sorry that I missed that. And thank you, Dawn, for yeah, I see it up here. At times there are some staff who've done this with their students, but don't seem open to your suggestions because it is so specific to each student. And, I think if we think about explaining to individuals, it's just like learning, right? We can have a general idea of how to teach students how to read. But each of our students is going to be on their own specific path to reading. And we modify for our students. We adapt for our students. And it's the same thing with feeding. Courtney said, oh, great point regarding the specific materials and approaches. The approaches, I found videos to be really helpful for families and school teams. Then if a new team members are added, they can view it. Yes, absolutely. Let's be efficient, right? We're all so busy. And there's so many technological resources out there today that we can use. I think we should take advantage of all of them. So the where, what, and how continued here, thinking about, again, and Dawn, maybe we can click on this link here for a second. This is just, again, we looked at this previously, but that example of a safe eating plan, and noting how in here there is information. Dawn's going to get that up. Thank you for your patience while we get to that. There's going to be information here specific to seating and positioning, and maybe we can't open it up right now. Utensils and equipment, diet, and there it is, diet and food preparation, specific techniques and precautions. Again, each of these is going to be specific for each of the kids, and we can't assume. We just can't assume, because I'll tell you, you may think, well, most children with cerebral palsy do best if they're seated slightly reclined in their wheelchair. Well, I'll tell you, I know a number of students and a number of children who actually do best if they are seated tilted slightly forward with their tray on their wheelchair and their arms resting on their wheelchair. And then they create more support here in their pharyngeal area, in their throat, so that they can then swallow more safely. So we can't assume. So we have to think about the seating and positioning for everybody. Utensils and equipment can be so different from child to child, from student to student, especially when we're looking at, again, some of our kids who may have oral motor issues and have very specific utensils that they use. Diet and food preparation is going to be so hugely specific for each of our kids, especially those kids who either have some sort of true oral or pharyngeal dysphagia, they are at risk for aspiration, or those kids who may be on the spectrum or have any sort of sensory pieces or components to their feeding, where they need very specific foods in a very specific manner, or they may be at risk of not taking anything in at all. And then those specific techniques and precautions. There are all sorts of things. Something as simple as putting a hand on a kid's cheek may be needed for some individuals to keep themselves stable. If you put a hand on the cheek of another child, it may throw them into complete refusal to eat. So really being careful to think about all of those techniques and not assuming that what works for one child or student is going to work for another. Okay, hands-on training. So what has been recommended, again, by some of the people that Dawn and I have learned from, is this 3-meal process. So in meal 1, the feeder, or the person who's being trained, observes and is allowed to maybe feed the student a few bites. I think about doing this a lot with children that I've worked with who might be little itty bitties learning how to bottle feed. And I want the parents to give them a few sips from that bottle. Meal number 2 is going to be that the feeder feeds for the entire meal, and then the trainer observes. So again, thinking about the person who is learning this skill, taking the lead now, jumping in, but still having that support person there, still having that support person giving them feedback and coaching them through problem solving through this meal experience. And then meal number 3 would be sort of that idea of role release, where the feeder feeds the entire meal. That trainer might still be nearby, should be nearby for assistance. And then there's some questions and some debriefing afterwards. So again, this is again why we spent a little bit of time here at the beginning, really talking about that relationship and making sure that we understand what it feels like to train somebody and what it feels like to be trained, because we are all professionals and we need to respect that. Again, there are individuals that I do, we do, you do. I love that. I do it, we do it, you do it. Meal number 1 is I do. Meal number 2 is you do, we do. Meal number 3 is you do. Oh, I want to add that in. I love that. Learning from you guys. I love it. But thinking about how, again, that can be a very vulnerable situation, and being respectful of being in the position of either being the trainer or the trainee. Okay. In terms of implementation, after a training, the team should mutually problem solve anticipated needs and how often to, quote, touch base or formally meet if needed. This is, again, going to be very specific to a student. There may be, yes, this is a wonderful way to support folks who are nervous about safety. Yeah, the I do, we do, you do. I don't know, maybe, Dawn, can we like copyright that or something? I love that. Like,
it's in all kinds of other learning.
Oh, so we can't.
So you probably can't copyright it, but it is a good teacher practice.
I love that. I love that. Thank you, Laura. Yeah. So thinking about each specific student, there are going to be some students who are very, very difficult to feed. And so we want to, again, touch base more regularly, right? There are going to be some students who you're like, hey, we got this. We are going to fly. They are going to participate. We've got this. And so you meet less. Ongoing communication with caregivers. You know, I feel like we have to be so thoughtful about this. I love nowadays, I do sometimes visit patients or consult at daycares. And there are so many opportunities now to use technology where, you know, the daycare provider just taps something on the computer and it's like, oh, there was a diaper change. Oh, here's a picture of them eating lunch today. Oh, here's a picture of them playing with their friends. I don't know that the schools have those types of pieces in place, right? And so oftentimes we revert to the good old notebook. Well, what happens to the notebook, right? It gets thrown in the backpack with all the other notebooks. And does the caregiver have time to look at it between all the other things they're doing in the evening or the afternoon? Do they even notice that the notebook's there and just think it's the student's other notebooks? So getting creative about thinking about binders or any sort of electronic communication, but making sure that it is something that everybody in the party has agreed to and it's useful for you. Another thing that's really important with implementation is to review that chain of command when concerns arise and reminders that the plan can and may need to change. So if there's a small concern, can you go to the speech language pathologist and get something problem solved? If there's a bigger concern, might we need to bring the whole team together? If there's a really significant concern, might we need to bring in administration? Might we need to go back to the medical team? That chain of command could look different depending on the concern, but I think that it is something that we should all be ready to think about because we would rather be prepared and have a chain of command in place than to just say, okay, well, we'll deal with that when it happens. All right, next slide, fidelity. We talk about fidelity throughout all of these webinar series. And I can't believe that it's already February and we're like rounding the corner to being done with these. I'm really kind of disappointed because I want to keep going. I want us to keep learning together. But stay tuned because we still have March, April, and May going. But the degree of exactness with which something is copied or reproduced is the definition of fidelity. So how do you ensure fidelity? Let's just put it in the chat. How do you ensure fidelity in your current district with other things that you're doing? Does it involve peer review, professional input, caregiver feedback, reviews of records? What are you doing to ensure fidelity in your situations that you may be working in, whether that's a classroom or one-on-one situation, if you're looking at school-wide or district-wide? What are some things that you already have in place? And that's what I'm hoping some people will put in the chat, because that then gives us something to work off of, right? We're already doing fidelity measures in our practices. We just may not think about them that way. So while people are chatting, I'll give an example of where I work actually seeing patients. We do fidelity by doing peer chart reviews. And every quarter, we are randomly assigned a chart to review and give feedback on. Courtney said, finding measurable ways to progress monitor the students' feeding. Yeah. That's definitely fidelity. Yeah. Another fidelity input may be, okay, here we go. Watch each other teach video in person and give feedback. Yeah, that's great to watch. And I was just going to give that example. I was going to say where I teach it at Marquette University, we do that, where we watch each other or we watch a video of each other teaching and then we give each other some feedback. I love that. Yeah, these are all great examples of fidelity. So you're already doing some of these things, and we just need to apply it specific to pediatric feeding disorders. Okay, so related to training and implementation, we're kind of on our last slide here, and I always like to leave time at the end for us to stop the recording and open up the chat and have a little bit of a discussion. So let's just open it up now. And what questions do you have about training and implementation? What concerns do you have about training and implementation? We're all here together to chat and problem solve. So let's hear it.
Another thought I had, Jennifer, related to fidelity is, is the plan being followed the way that it was written? And is it still effective for that student? So just like anything else within the IEP, are we implementing the accommodations and supplementary aids and services, and are they effective for that student? So just another consideration when we're looking at fidelity.
Yeah, I love that idea, Dawn, because I think it's so important for us to remember that kids change, and some kids change really fast and some kids change over time more slowly. And so recognizing their change trajectory and looking at that in a way that gives us the opportunity to say, this may be effective now, but this may not be effective in a few weeks when Billy gets a new chair.